Good afternoon, and welcome to everyone joining us. Fair for All is a nonpartisan organization with the mission of safeguarding civil liberties. I am Dr. Nikki Johnson, the co-director of Fair Medicine, and we welcome you to today's webinar. We recognize that the health profession and scientific communities have abdicated their duty to safeguard the ethical standards of the profession by placing political ideology over science. As part of our effort to return medicine to the fundamental principles of the Hippocratic Oath, we are discussing informed consent and the harm caused when it is lacking. My guest today is Dr. Roger McFillin. Roger is a board-certified clinical psychologist and executive director of the Center for Integrated Behavioral Health in Bethlehem, Pennsylvania. He is one of the preeminent critics of the psychiatric diagnostic system and the harms of psychiatric drugs. Oops, sorry. Dr. McFillin hosts the Radically Genuine podcast, which has propelled itself into the top 1% of global downloads. He is also the founder of the new nonprofit Conscious Clinician Collective, which aims to align like-minded mental health and healthcare practitioners who prioritize informed consent and medical freedom. In its early fundraising stage, the organization aims to create a comprehensive platform to search for local clinicians and gain access to critical information kept out of the mainstream to make informed decisions regarding mental health. Back in July, Roger joined us to talk about SSRIs, or the drugs that used to treat depression. And he returns today to follow up on some additional questions that we want answered, and some concerns that we have about this issue. So thank you, Roger, for joining us today.
It's an honor to be back, Nikki.
All right. So the last time you were here with us, you enlightened the FAIR audience with data about the effects of SSRIs. Would you just kind of refresh our memory here, briefly summarize your thoughts on the critical data that highlights the impact of SSRIs on treating depression and the most common adverse effects of these drugs? And particularly, I know you talked about the chemical imbalance theory and some of the main adverse events. So if you could highlight those things, it'd be great.
Sure. I think this is a great opportunity to speak a little bit about historical context, which I did not get the opportunity to discuss previously,
Awesome.
because we might not have a full understanding of what depression is sitting here in 2025. You might ask 25 different people what depression is. You might get 25 different results. And so it's really important for us to know how it's shifted and changed over the past century. There's this great book, 1968. It was called The Epidemiology of Depression. Charlotte Silverman wrote it. And with data, she identified that dating back to the 1930s, the 40s, and 50s, again, this is periods of time where there was the Great Depression, World War II, a number of other social factors throughout the United States. Fewer than 1 in 1,000 adults would identify experiencing clinical depression annually, and it was almost nearly absent in children and adolescents. So what we talk about right now as almost being an epidemic historically is not. And so we have to ask ourselves some pretty critical questions about why that might be. Interesting enough, too, in 1964, a psychiatrist by the name of Jonathan Cole wrote an article called The Therapeutic Efficacy of Antidepressant Drugs in the Journal of the American Medical Association. And what he argued at the time was there's no reason to have or develop any antidepressant drug because of all psychiatric conditions, depression had the best prognosis, meaning it was just episodic and it would resolve naturally on its own. I think if we got in a time machine and even went back to the 80s, the 70s, and the 60s, and we asked people, if you're feeling depressed, if you're dealing with the blues, something we've been identifying throughout the course of human history, it's not like it's a new condition, what would you do? And people would say mostly nothing. It's an episode. It's going to resolve on its own, and it's representative of things that we're experiencing in our life that we probably have to face. Well, it's not that anymore because of a narrative that has been sold to the American people in conjunction with the pharmaceutical industry's desire to sell more and more psychiatric drugs. And what you see is this ever expanding idea of what depression is. And here we are. I think depression as a clinical diagnosis, as a medical condition, has lost its value. It's an umbrella term now. When you talk to young people, meaning adolescents, 20-year-olds, 25-year-olds, even up to millennials, they'll use depression as a word to describe a number of emotional states, from sadness. We never even use the word sad anymore, to boredom, to emptiness, to anxieties, to fears. It's this large general umbrella term for the discomfort of being human.
Yeah.
And we've medicalized and we've commercialized that term to drive more and more people to the drugs. And so this narrative has been pushed out, it started to explode throughout the 1990s when we approved Prozac in 1987, because the pharmaceutical companies, starting with Eli Lilly, have been some of the best marketers. And this is a story of marketing. It's not a story of science, in
Yeah.
which they hired some of the most prestigious academic psychiatrists to pretty much act as thought leaders, to sell this narrative that depression is associated with a chemical imbalance of key brain neurochemicals, most specifically serotonin, the serotonin hypothesis. Now, this was a theory
Yeah.
um, that supports the targeting of serotonin, that if you can increase the availability of serotonin, that has a direct implication of mood. That's completely debunked. There's no scientist right now that or serious scientists would support such an idea, that the complexity of the human experience is associated with one neurochemical. And a 2022 umbrella study came out that really clearly demonstrated that all the scientific research that we've been able to do throughout the decades has never demonstrated that depression in any way is associated with serotonin. Now, serotonin is a very complex system throughout the entire body. And then the question today, when we start talking about the detrimental effects of SSRIs, their efficacy, and what alternatives are, which is a moral and legal imperative, an ethical right for informed consent, is we have to acknowledge that it has been a profound experimentation on the brain, what we've been doing over the past 40 years with mass
Let's
prescribing of SSRIs.
let's pause right there. There's two concepts here that you touched on that I can definitely relate to. And I think that the health professionals who are watching this, physicians, psychiatrists, the people who prescribe these drugs can attest to, at least I know for sure in my training. I mean, I can think back to the day in medical school where we actually learned about this and we talked about this. And we did absolutely talk about um, the chemical imbalance theory as it actually was a theory. It was never sold to us that this was like definitively the truth. But when we actually started going out and doing rotations on, I remember my clinical rotations in psychiatry, it was treated as if it was the truth and not just the theory. I think it's so interesting the way the shift that gets made from the classroom and the scientific discussions about this to the actual clinical practice that goes into it. And I do believe that, and the other piece of it is during my psychiatric rotations and during my time in my own, medical training in internal medicine and pediatrics, it was it was actually a lot more obvious to me that the psychiatrists were actually a lot more in tune with the pharmaceuticals. I mean, learning that stuff was a big part of their residency training. I mean, they actually sat and had specific journal reviews about these medications. And I just, so it truly fascinates me that I think more so than many of the other specialties, they are aware of trials and drug effects. And so I think what's concerning to me is the thing that you brought up. I mean, stating that the pharmaceutical companies have a lot of influence here with this and are driving this conversation and this narrative. I am wondering if like, how it got to that point where you leave the classroom, where you have a thinking brain and you can, debate these ideas and come to logical conclusions, but then you get on the wards and you get into your subspecialty, and then you're starting to be trained that this is just one way to practice. To me, overall, that is, one of the most frightening things about this. And anyone who is, I don't know that residents in training, especially young interns, feel empowered to push back and ask questions anymore. I think it's a little bit different than when I was training. But now I just think I think back to my rotations, and I think that just sitting there, like, with the implication, like that this is no longer just a theory. This is exactly what it is, and this is why we use these drugs, and we take the word of the pharmaceutical reps and their companies over our own thinking brains on this. I don't know how that switch happened, and we've seen something recently, and not to go off completely off topic, but with the research revelations about Alzheimer's, and how some of that data was manipulated to believe that there was amyloid deposits were the actual cause, and then we should be going out and targeting those. So I see a lot of similarities there. So could you talk a little bit more about how you think um, this, what I would call social engineering, happens
Yeah.
in the profession?
And it's kind of the perfect time to have this conversation. We're the first week into President Trump's new term, and as you know that, Bobby Kennedy has been nominated to head HHS, and one of the mandates, really, for the Trump administration and for Bobby Kennedy is to be able to root out the corruption between government, industry, and our
Yes.
major academic institutions. And so, what you're referring to is a bit of a larger systemic issue around the entire sick care model in the United States. And as we sit here facing a chronic disease epidemic, rising rates of death by despair, we have to understand what are the root causes of a lot of these illnesses and conditions, and how did our government officials, the FDA, which is by theory supposed to at least establish some degree of efficacy and safety for these products, how were they corrupted? And so I go back to early 1990s. So the first, when we're going to talk about just SSRIs, Prozac was the first drug that opened up the gateway here for the revolution of targeting brain chemicals with these pharmaceutical products under the disguise that they are psychiatric drugs that improve conditions. I think it was around 1991, the FDA decided to have a hearing because um, once they approved Prozac, they were flooded with calls and reports about what's called a stimulation effect to the drug. So there was increased mania, suicidality, psychosis, and they opened up the hearing to be able to further investigate into the clinical data that was provided by Eli Lilly. Now, one of the things about how drugs have gotten approved is that you only need two positive trials in order to determine efficacy. Okay, positive trials means they has to have a statistical significance over a placebo. Randomized controlled trials are the gold standard. So um, they needed to prove that the drug outperformed a placebo. So that's the efficacy part. We're kind of fooled into believing that these drugs are proven to be safe because there is no requirement for long-term evaluation, and nor has there been with SSRIs. But
Yeah.
what
So,
was
and just to go back a little bit, rewind a little bit, but for people who aren't familiar with the process. So the first two, the first step is to prove that the drug is effective, right? Against a placebo. And
yes.
then there's another phase. The next phase is safety, right?
Well, not necessarily. So you can do an
Okay.
eight. You can get
It's
an
supposed to be safety.
in theory, I
Okay.
suppose, but you'd have to study the drugs long term to do that. I think there's a lot of laws um, that were created throughout the '80s to really shift FDA's role is to get the drugs to market as soon as possible. And then really it's trusting the doctors from that perspective.
Okay. Yeah, yeah,
Um,
yeah.
but it's not that difficult to be able to create a trial um, to show that your drug can outperform a placebo effect. So
Yeah.
this is a really important piece. I want to share it again because I shared it in the last time. This is how the drug companies have been able to master that. One, you have to first create an outcome measure where that if your drug targets certain aspects, now these are active psychoactive substances that act on the brain, so they affect people. You have a drug effect. What I say is they're not antidepressant, but the drugs do have a range of different effects for people. The most frequent one is emotional blunting. So
Mm-hmm, mm-hmm,
if you create an outcome measure that somehow reflects that a blunting of emotion is a positive outcome, then you can try to get a difference. But even with that, there were so many problems in the original trials. Germany failed to approve the drug because they said this is a dangerous drug. And the United States aligned with academic psychiatry and the pharmaceutical companies to create the narrative that this is some kind of scientific advancement. What they found in that 1991 hearing going back is like about 38% of the people who were prescribed the drugs had a stimulating effect. There was increased suicidality, agitation, a number of adverse reactions ranging all the way to mania and psychosis. Emotional blunting was another response to the drug. In order for them to outperform placebo, there's something called placebo washing. And so what you can do is most of the people who are coming in on these trials are on some kind of drug. What you do is
mm-hmm,
you abruptly withdraw them from the drugs.
mm-hmm.
And so the group that's not getting the psychiatric drug, not getting the SSRI, they're induced into withdrawal. And then you provide somebody on an SSRI, and that helps with potential withdrawal symptoms. So that creates a difference between the two groups. They also, when they withdrew people from the drugs, they did an initial placebo round, and some people respond to a placebo more than others. And then the ones in the group that responded to placebo and had a higher response rate were removed from the trial. So in my evaluation of the data, they should have never been approved based on efficacy.
Mm-hmm,
Now
mm-hmm.
safety is the question. Obviously, how do we know that 38% of people had this stimulating effect? Well, from court documents, from product liability cases, and from Freedom of Information Act. So this type of stuff is available. Doctors are not provided this information. Doctors are generally provided the textbook information, which is funded by the pharmaceutical companies because
Yes.
they have hired the thought leaders. Okay, now there's other systemic issues. You throw people out into doing the job of a physician, and you know how difficult it is to be a physician in today's healthcare environment, and the amount of hours that a resident has to put in, the amount of debt that you take on. The mental health of physicians is quite poor. I think it's one of the poorest of all professions in the
Yeah,
United States. To say
absolutely.
that to say that you have the time to go in there when you're treating patients and you're following your advisors and you're trying to just get through residency, survive with everything else that is going on in your life, you're probably sleep deprived, that you actually have the availability to critically analyze research and ask those questions, is kind of a kind of a fallacy. What has become of the healthcare system is most people are following guidelines, and you're trusting those
Yeah,
guidelines, which are
yeah,
coming from major medical organization. And so
correct.
this is really important because I'm
And even worse though, it's not even just that it's not like major organization. People also don't understand that how the major medical organizations come up with these guidelines. They take a select group of people and sit them on a committee, and then they come up with these guidelines. And often those people do have ties back to industry or, or, or again, are doing some of the research on these products as
yeah,
well, right? Yeah,
absolutely. They do fund the major medical organizations. If you just have to go to the American Medical Association, the American Academy of Pediatrics, just go look who their major donors are.
yeah, yeah,
They're biotech, they're medical, or they're nonprofits that are propped up by the pharmaceutical companies.
yeah.
So 2004 is a very important time, I think, in this narrative because um, it was a time where we had an FDA hearing for the increased risk for suicide and violence in adolescents. So when we're talking about what are adverse effects, I'm already mentioning a
Yes.
bunch of them, right? That stimulating effect.
Correct. So the
And
stimulating of it, and oh well, can you even see? I could see the argument for the stimulating effect too, because okay, if you have a person who's depressed, then they need some stimulation, Roger? You know, like like how is that a
well,
negative effect?
yeah, if
You
there
know,
were if there were no other health problems related to that, right? There was no
right.
downstream consequences of taking a drug. It's a drug effect,
Yeah,
right? And
yeah,
it could be some mild energy that a person gets. I guess you can argue ethically that there's not really a problem. But this gets into other aspects. Most of the people who are provided these drugs are not depressed. They're not even in a severe clinical range because we have really expanded the definition of depression. We're also giving these drugs for anxiety, OCD, any stress related condition, gut issues. We've expanded the market. We're sending these drugs out for all conditions they haven't been thoroughly evaluated for. Not
yeah.
that they've been thoroughly evaluated for depression either. But I want people know how dangerous this is. In the 2004 FDA hearing for increased risk for suicide and violence, it was revealed that 12 out of the 15 pediatric trials, um, SSRIs for children and adolescents failed to outperform placebo, and the FDA rejected the application of 6 manufacturers seeking approval at that time. Right, that is enough to be able to say we do not have the data to suggest that these are either effective or safe, and so there
Correct.
was no reason to believe Prozac would be any different. Now there are long-term ties of Eli Lilly with politicians. So getting back to the early 1990s, George Bush the first was a former board member of Eli Lilly, and his vice president Dan Quayle was from Indiana, and that's
Mm-hmm,
where the headquarters are for Eli Lilly. And on the
mm-hmm.
Bush staff were a number of former Eli Lilly employees. You know, it was in 1991. The drug should have been determined that it was not safe, and it's barely outperformed placebo, and that's even with manipulating trials.
Yeah.
But it didn't. It started the narrative, and there's no reason from a data or safety perspective that this drug should have ever been proved for children and adolescents. And so that's why I'm at this point I'm very clear and very direct with people that there is no evidence that we have any antidepressant drugs. And when you look at the risk benefit profile, the risks of these drugs are significant and they outweigh any potential benefit for the drug, which is mostly expectancy effects. And we have
Okay.
good data to suggest that when we've used NIMH money to evaluate through trials. There's 2 really important trials uh, that evaluated these drugs in more real world settings. One of them is called the STAR-D trial. And so prior to 2001, there was really an attempt. This is going back to how clinicians are trained. There was this attempt to try to understand what were the real world effectiveness of these drugs, because in a trial you selectively allow for people to come into the trials that are going to give your drug the best opportunity for approval, and you're
Yeah.
not always treating the people who really require it. And so if there's a more than double the risk of a suicide event when you take an SSRI, I'm going to argue it's much higher. Well, those are the people we really want to help, severely depressed at risk of suicide, right? And so when you remove them from the trial, what are these drugs for? Who are they for? Under what conditions and why? So they attempted to create a trial, about 4,000 participants. This is important because it's funded by our federal government. And the step one, there's 4,000 participants across the United States in healthcare settings. Step one was to start everyone on an SSRI. At the time, it was Celexa. Okay.
Mm-hmm,
Those
mm-hmm.
those who didn't remit were placed into step 2 or 4, which they could be switched to another SSRI. You could add another drug. You can add a therapy, which at the time was cognitive therapy. There was flexibility with all the doses, and these lasted 12 weeks, right? And so we got to see, do these drugs in real world settings, are they effective? And they used 2 outcome measures. One was the Hamilton rating, the Hamilton Depression Rating Scale, which is
Mm-hmm, mm-hmm.
what's been used in the other trials, and another is a quick it's called the quids. It was a quick review of the symptoms that the doctor believed the patient was experiencing. And so in 2006, when they published the data on this, they said that 70% of people who went through all the steps and stayed in the study achieved remission uh, uh, by 12 months at the follow-up, right? And so this is published out there. And I was in graduate school at that time, and I had psychiatrists telling me this is it. It is now proven that antidepressants are effective with close to 70% efficacy rate for people who have severe depression. That actually, the original paper cited 67%. But in 2010, through a Freedom of Information Act, all the data was reanalyzed. And what they saw, and they published subsequent papers on this, is they deviated the protocol once they realized that people were not getting better. That 67% then decreased to 38% immediately. And then what was called a stay well rate, like after 1 year, were they still better, went down to 3%. And that is clear scientific fraud. The authors of that study have not denied it, but the paper hasn't been retracted. And they still use today, when we talk about treatment guidelines, that STAR-D trial is used to justify real world use of depression medications, antidepressants in clinical practice. And I would argue 95% at least of prescribing healthcare practitioners are not aware of this. So we have no good evidence. And the other one was for children and adolescents. It was called the TAD study in 2003. And the thing that we learned from the TAD study is Prozac didn't outperform placebo, but those who went on Prozac had a near 10% likelihood of entering into a suicide event. And that's really, really important. And just to know the level of corruption that exists, the original authors did not present the suicidal data in the original paper. And again, it goes back to these Freedom of Information Acts. Other more ethical researchers then have to analyze the data and publish subsequent papers. But the drug companies and these academic psychiatrists are pushing out saying like the TADS is another study that shows the effectiveness of these drugs for younger people. I mean, this is extremely concerning. I got the exact data here. 9.2% of kids became suicidal taking Prozac during that study. And then any effectiveness.
I remember this well. I mean, this was in the middle of my training as well. I remember this coming out. And there was this huge shift. Now that this is out, it's like, okay, then what do we do? What we do with this? Now there's an FDA black box warning, but now we're going to just, we still might prescribe them. We just have to warn our patients about it. It's
yeah. So let me tell you what's happening in
yeah.
reality.
Yeah.
We're not more conservative with a drug that's never been proven to be effective and induces suicidality. We're actually giving it more. We're prescribing it more and prescribing it to at-risk teens. And so we are seeing increases in suicidal ideation, psychiatric hospitalizations, and self-harm, mainly in the population that we're providing it to, which is adolescent females. Adolescent females at risk, a number of aspects what they're at risk for during this vulnerable developmental period. We're prescribing near 20%. And this is unbelievable. Near 20% of adolescent females are being prescribed an SSRI.
Yeah, absolutely. Okay, so all right. Okay, to me that's a huge topic. And so let's shift a little bit because it does get into kind of my next question for you that I want us to just sort of begin like kind of tiptoe around this discussion. But really, okay, you've been critical about kind of the diagnostic criteria that we use as well. I know for sure that the diagnostic manual that is used that everybody quotes a lot, which is now currently, are we at DSM-6 yet, or are we still DSM-5? I can't remember. Okay, but that wasn't that was originally intended to um, be used just sort of as a sort of a billing and diagnostic code book. It wasn't necessary. It wasn't supposed to be used for making diagnoses and treating our patients. Right? Do I have that interpretation correct?
Correct.
Okay.
Original
All right. The
intention to
second
be
piece
part
of
of the
it. So
system. Yeah.
then what should we be using, or how should we be diagnosing really, kind of a clinical depression, or where do we go from, the normal response, the normal human emotional and psychological response to something that makes them sad? How do we go from that to some sort of diagnosis, especially that is, I would call, a level of depression that is making you a non-functional human being.
Yeah.
How do you diagnose that? And then what do you do to manage that? So let's get into we know the drugs now. Let's just assume everybody who's watching this now knows that the drugs now don't have efficacy. They seem to have more side effects or adverse effects than any benefit, to the psyche. So what do we do? Like, what do we do with these patients who come to our clinics?
Okay. Now that's the perfect question. I think that's going to probably take a lot of our discussion today. So
Yeah.
first and foremost, um, statistically speaking, that severe depression, which you spoke about, is actually quite rare. Now, I see it. Obviously, I'm a clinical psychologist, but the overwhelming amount of people that we are assigning the diagnosis and prescribing the drugs don't meet that threshold because the threshold is so low from the DSM. 2 weeks of feeling sad, and we hand out these PHQ-9 screeners that were developed by Pfizer. Howard Klopnick, a marketing executive, was to get more people to identify with the diagnosis. And what you're speaking about, Nikki, is there is a cultural factor to this where at this point most people don't know what is normal. It's an anti-human perspective where the polarity and the normal aspects, the ups and downs of living, are kind of pathologized. We've medicalized it to say like there's something wrong with you if you have these negative emotional states. And there's been a war on emotion. So we've shifted our idea of what it actually means to be human over the course of 40 years to kind of fit this model. I think it's of a greater anti-human transhumanist movement, but that's another discussion for another day. And so what most people coming into the healthcare centers, let's say it's a pediatrician, for example, 80% of these drugs are prescribed in primary care, is what we know is exactly what they knew in the 1960s, that these conditions are episodic and no treatment is required, that we are naturally resilient, that the stressors that would provoke that period of time will naturally resolve themselves for an overwhelming amount of most people. Now, I have talked to enough pediatricians that I know the challenge because one gentleman said to me, he goes, what am I supposed to do, Roger, when I have a depressed teen coming in here who tells me they're thinking about suicide? My clinical guidelines tell me a frontline treatment is an SSRI, and if something happens to that teen, then I can be held liable for not following the clinical guidelines. And that is the power of this corruption, right? That it influences how a doctor is going to treat their patient because of fear of liability.
Yeah.
And that's
Yeah.
really concerning because now they're going to prescribe a drug that's going to increase the likelihood of a crisis event, not dissipate it, not because they believe that's in their best interest as a independent functioning clinician, but because they work as a greater system and they have to follow the rules. So the truth of the matter is we have to get back to supporting resilience again, normalizing challenges, especially during vulnerable developmental periods, such as adolescence. But we also have to understand what are some of the root causes that are influencing the chronic disease epidemic, because our health and our mental health are intertwined. You cannot separate them. Although we have a
Absolutely.
system that tries to separate it, there's a lot of reasons why people are just physically unwell right now. And I call it
Yes.
the disease of modern living. And so what
Yeah.
is the disease of modern living? Well, we are more socially isolated than at any other point in history. We're
Yes.
not meant to be socially disconnected. We're meant to
Yes.
move our body, be connected to nature, be outside in the sun, and we're supposed to
Yeah.
eat foods that are real,
Yeah.
right? And
And when you
so,
say that, it just puts me in mind. I wish I had a chart right now. We can actually look at the spike in diagnoses for for mental health conditions, depression and anxiety after the pandemic lockdowns occurred. It
absolutely.
was, there's a huge association with that time period, and the common denominator was social isolation. Lots of work has been done on this area, so we know that this is a real phenomenon that we're not addressing. So,
Yeah, what's interesting is some of the best mental health interventions are free.
yeah,
And
absolutely, absolutely,
And
yeah.
so what happened during
Yeah.
the lockdowns is there's a number of things that happened. There was a lot more screen time, which is detrimental
Hmm.
to adults and children, more
And
so
true, yeah,
children as
yeah,
well. You're exposed to this blue light, which has detrimental effects. It impacts circadian biology, affects sleep. We know the vulnerability of social media exposure for teens. There's the isolation. You're getting them off their schedule. You're taking them away from their extracurriculars. You're taking them away from things that have really motivated them in the past and what are absolutely necessary for the development. So when we talk about common sense approaches to mental health, that's why I'm so in support of this administration's attempts to be able to get this country healthy again, because it is not just another pill for every ill, because that's what we do. We're prescribing a drug for every symptom without identifying the root causes.
yes,
So let's
yes.
just say depression is a label, and it's on a continuum about as level of impairment. So the intervention has to meet what the degree of impairment presents with, right?
Yes. Okay. So look at this. So this also brings up. You use the example of the busy pediatrician, but also in your recent Substack, I'm going to quote you. You wrote, primary care physicians have become the frontline dispensers of SSRIs, caught in a system that demands quick solutions for complex human suffering. These doctors, already overwhelmed with impossible patient loads and limited time, become particularly vulnerable to pharmaceutical messaging and standardized treatment protocols. They're given simple narratives about chemical imbalances and handed prepackaged solutions in pill form, with prescription pads becoming an easier option than navigating the messy reality of human distress. So, that's a great summary of what we just talked about, but the practical issue is still there. You have these busy doctors, with patients coming to their clinic, their clinical panel is stacked, and especially if they are working for a large health system that employs them, and they take insurance. They have to see a number of patients in a given amount of time. There needs to be a practical response to this. There isn't a mental health professional available, to kind of coach patients through this. And physicians are trained. We're trained to actually diagnose and treat disease. That is our model of the American healthcare practice. Pediatricians and family practice docs and maybe some internal medicine docs do have have preventive medicine kind of in tuned in their brain too, and they do want to prevent disease. But for the most part, and I would say pediatricians are more so in tune to this type of thing, but we're still even going about it. We want to have a solution when a patient comes to us, and we want to have it right within that 15-minute time frame. And so, like, what's the practical solution? How does a clinician, um, you know, solve this problem, or become a part of the solution to this problem? That's, to me, that's going to be the answer to this. Is to get us out of this, is you have to have the people who are on the front line responding in a positive way.
So I've been having conversations probably a good year and a half to 2 years now, trying to answer that exact question. And here's how I'm going to try to answer it. So first and foremost, I do not believe that the system that's creating the problem, that the answer is going to be within that same system. So when you identify the problems of 15-minute at most sessions, because now it's become financial, that's intertwined with the Affordable Care Act in ways that I can't even be able
Yes.
to get involved with today.
Yes.
So we've eliminated the independent practitioner. So
Yes.
in that system, nothing is
Yes.
going to be done in 15 minutes. But let me give you the practical, because I know that there's many good people who are working in that system and want to do something. My answer to that is something called watchful waiting. Watchful waiting is where you take it seriously, and you communicate with the parents that there's reasons that they're feeling unwell, they're struggling. We have to identify what those causes are. They're not going to be able to necessarily be done today, but I want to take this seriously, and I'd like to follow up, in a week, right? So like these weekly 10 or 15-minute meetings where you're taking it seriously, and you're connecting with that team to see how they're doing. Evidence shows that just that attention, taking it seriously, is enough to resolve the condition in a large amount of people. So by doing nothing other than the watchful waiting and taking it seriously, will let it naturally resolve without the harmful interventions. Can you do some other things? Yes. You can provide parents education where you're decreasing the phone time, you're taking a look at their sleep, um, you're trying to improve activity and connection outside. So there's attention to the problem that's being given, and it's monitored safely. So in a primary care setting, that's my first recommendation. What's my
Yeah.
larger recommendation?
Mhm.
We need to pull people out of the system. And so what you're seeing right now is that there are medical professionals who are removing themselves from the umbrella of that system, that's intertwined with complexities in insurance.
Yes.
And they're
The
creating,
financial incentive structure of it all. Yes.
when the incentive is to keep people sick, people are going to get sick. And
Yes.
so if there's doctors, ethical doctors, that are pulling themselves out of the system, and they're creating new models where
Yes.
you can pay cash out of pocket, like a subscription model.
I
um,
have a direct primary physician, just so just so you know, I am fully on board with this model.
yeah, I think
To me as a solution.
Yeah, I think there's a lot of people who are probably listening who support freedom of choice.
Yeah.
And the great thing about being in the United States of America is that a market can dictate, um, you know, what is going to be the best care. So like when you're being harmed by a system, the market needs to be able to speak by not continuing to use that system that is creating harm. So the more people that leave it, we're creating new incentives. So that new system where it's cheaper, it's more cost effective, and it's better care. So people are
Yeah.
saying they get like an hour with their doctor. So you can really
Yep.
evaluate the problems and concerns. The other
Yeah.
here is the
Yeah.
mental health industry. So the mental health industry and therapists are part of this problem as well. So we're talking right now about the drugs and being prescribed by the doctors, but the same kind of conditioning, I call brainwashing, has infiltrated all aspects of the therapy relationship and the therapists that are out there. So when we
Yeah. Yeah.
put things into just two camps, like, hey, mental health is either go see a therapist and go be placed on a psychiatric drug. That's when we see harm. So it's time for us to have conversations. Okay, what are some of the meaningful aspects of mental health care? Okay, a strong relationship, right? That doesn't have to just be done in therapy. How about your church communities? How about
Hmm.
your elders, your family, your coaches, your teachers, right? We have to get back to the fact that we are a community and relationships matter. And are, when people believe that they're cared for and their life is important, that's how people start feeling better. When they feel alone and the people don't care for them, then you're gonna create a market incentive where the greatest relationship you have is with a therapist, which is sad in my ways, because that's a professional relationship. Not that therapy has its value in the right time, in the right place, with the right person under certain conditions, but we have to be able to acknowledge that we have created shifts in our culture to commodify mental health, and we're pushing people down the two directions. So those relationships, that community, that integration are very, very important. And the same thing, like, what do you think is going to have a better outcome with anyone who is just feeling down, low, depressed? If you go and you create changes in lifestyle with diet, decrease phone use, and improve your activity level, and you compare that to someone just being prescribed an SSRI, we know that those lifestyle changes are going to really outperform the SSRI
Absolutely.
without any
Yeah.
of the negative effects. So we have to push the conversation to back to common sense approaches to living well, and even normalize struggles, because I think struggles are necessary and transformative. They're part of the human experience, and we have to be very careful where we're giving up our humanness, where um, where we believe that there is some existence without pain, without suffering, without struggle, and that's somehow a better experience, because that's not how emotions work. Emotions are energetic. They are there to serve us. They're divinely inspired. It's over hundreds of thousands of years as a human being, we have evolved. There's reasons we should feel anxiety, anger, sadness, loneliness, and it should drive us for change. One of the reasons I'm
Yeah.
on this call right now is because I'm angry about whatever is happening.
Yeah.
So in
Yeah.
no way do I want to
Yeah.
lose that anger. And if someone who's abused or assaulted or in poverty, have lost their parents, those emotions are not to be pathologized. Those emotions make sense, and they're there to serve them through a very difficult time.
Yeah.
And so
Yeah.
that's
I
a bigger
think
problem.
this is, I 100% agree with what you said about how I think this is a broad, and a wide problem, culturally, and in our society. I definitely think that this closely relates to the phenomenon of gender dysphoria. I think it became a diagnosis, when, it is a child's normal response to something that's happening in their life. It is a normal part of development to consider your identity and your place in the world and fantasize about different things, and but we've come to pathologize it and then started to medically treat that problem. I think these two are very, not even just parallel. I think they're one and the same, in the way that we're going about treatment for them. And someone actually put that in the comments, something similar, to this. This all sounds unethical. My mind shouldn't be blown because we've done this to kids with puberty blockers and hormones, but my mind is blown by these seemingly deliberate harms just so some people can make some money. Can you speak to that a little bit too? I honestly don't think that the vast majority of health professionals are in this to make money, off of these interventions, these pharmaceutical interventions. But there are definitely people, who are benefiting financially from this. What are your thoughts about there being some sort of nefarious attempt, by like, is there some like evil wizard somewhere who's actually thinking this stuff up, and coming up with more ways to make money off of people's pain and suffering?
Yeah, I don't look at it in terms of like an evil wizard. It is exactly what capitalism is that you create a product and you try to sell the product. And so when it comes to pharmaceuticals, for example, or medical interventions, the more people that require that medical intervention, the better that you do financially. And these companies are, um, they're devoted to their shareholders. I mean, that their job is to show increased sales every year. Let's just take the pharmaceutical companies, right? Like, you need to be able to demonstrate that the sale of the drug is going to continue to increase. The only way that's going to be done is if you have more people identifying with the disease. So it's a part of a greater model of them being beholden to their shareholders. Now, the individual doctors, to my knowledge, that are not benefiting at all from this. They're just part of the system. They're a cog in the
Yeah,
system.
yeah,
And that what happens at the greater level, like let's say the hospital-based system, which has bought up a lot of doctors, is yes,
yes,
they make more money the more interventions there are. There are more drugs that are sold, the more
absolutely.
interventions make more money. So there's a financial incentive to do so.
Correct.
going back, you made some great points about gender dysphoria, for example, because that speaks to how if we pathologize the normal, then we can create more customers. And there is nothing actually more normal than the adolescent period of identity development, including the individual struggle between masculinity and femininity, right?
Mhm,
that expands beyond genders. Like we all have masculine sides to us and we have feminine sides to us. Now that has been corrupted to create all these different kinds of genders. Like if you feel that or you experience that, that means you're not your biological sex. That drives gender confusion. That drives ideology. It also drives people into a system. So there are multiple avenues of people to benefit, and that certainly goes back to the incentive structure that exists. We should be aware of that. And it's our jobs as individual consumers, as families, as conscious individuals to protect ourselves from that, to protect our children, to be
yeah,
able to support candidates that respect our individual liberties and our rights. And more than ever, we have to protect our own minds because the algorithm, the power of this technology is highly influential that if we're not careful, we're not thinking for ourselves anymore. We're just absorbing the information as if it's fact and it's true. And we've seen this in the mental health industry with affirmative care models. The affirmative care model has conditioned clinicians to think that they're doing the right thing by affirming a
yeah,
reality.
yeah,
They're thinking that's compassionate. And then
yeah,
you're afraid to actually even say what you might be really thinking because uh, essentially, this is somebody in front of me who's suffering and they believe that uh, the way to receive relief is to do something that is potentially permanent and harmful. And we want to protect people from harming themselves long term. We haven't been able to
correct.
do that. And that's why we
Yeah,
have a large detransitioner movement. Like, I mean, what we have done is absolutely immoral. People have defigured their bodies within this ideology. And you have women who are unable to conceive, they've gotten themselves out of the cloud of that influence and realize I was just a struggling teenager, or worse, there was a sexual assault that I never said, or I was being molested, and I just hated my body, which is a
yeah,
trauma response. And
yeah,
so I'm hopeful that we are just getting ourselves outside of that this period of time, that has kind of been like a
yeah.
8 to 10 year period of time where we've all been so mass conditioned, and there's an awakening.
Yeah,
And so I
I hope
hopefully
so
the
too.
awakening is the veil is lifted and people understand the the conflicts, the corruption, the veil of influence, and so forth.
Absolutely. And so, and I think, and with these, just even just these two examples of conditions that we were seeing, from humans, you've given some great um, insight into, what number one, why is it being diagnosed in the first place, or why are we seeing it, but also like what the response is. I actually don't like the phrasing watchful waiting because I think everything you said was not watchful waiting. It was much more of an intentional, um, intentional waiting, and with some intervention. And I think both of these things can, we can actually, find cures or at least a way to manage these human conditions with these types of non-pharmaceutical and non-pharmacological, obviously, interventions. On the other hand, though, going back to the SSRIs, we have a bunch of people who are on these drugs. We've talked about some of the side effects. One of the questions in the chat was, what are some of the bad health outcomes that you're alluding to from SSRIs? This is a social media question, and I just want to people. We did talk a little bit about this in the beginning of this, but we actually did have a webinar back in July. Gavin, maybe you could put the link to that in there for the person who's answering that question, that we've actually talked about those things. But getting back to the meat here is, how do you have a person who comes to you with these side effects, or I'm a busy clinician in my clinic and I have a patient who's been using these drugs for years, or many months, and they're telling me about these side effects. They were telling me about their apathy, their sexual dysfunction, their overstimulation. How do you recommend, first of all, if a patient's on these drugs and been prescribed them by another clinician, at what point do you recommend that these drugs be discontinued? And then how do you manage that? Tapering off or discontinuing the drugs, any related withdrawal effects? And then can you talk a little bit about the reversibility of the adverse effects of SSRIs?
Great questions. Okay. So first and foremost, we have to recognize that the drugs themselves create dependence much quicker than has been previously discussed. For some, it's, within the first week of use. And what we know is that once you take this drug, it is inducing a chemical abnormality. So, it's the opposite of correcting something that's abnormal. It's inducing it. And so there's this downregulation effect where the brain responds and tries to compensate for this abnormal increase of serotonin and tries ways to reverse it. So it's like this defensive compensatory approach by destroying its own receptors for serotonin. So this is why we have long-term problems with these drugs. It decreases the amount of receptors for serotonin on the nerve cell. And what we've seen in some regions of the brain, it may result in like 40 to 60% loss of serotonin receptors. So we are disrupting the serotonin system, one of immense complexity. There's like over 860 billion neurons. And in animal studies, we've seen that some of these conditions can be permanent, and it's certainly affecting the frontal lobe. And so why it's so important to protect adolescents going all the way up to 25, is because this is a period of time of such rapid brain development. And so the first and foremost is we want to prevent young people from going on the drugs in the first place. If they do go on these drugs, they're having some adverse reaction. Okay. The most common is emotional blunting. And so not everyone sees that as an adverse reaction. But from a psychologist perspective, I'm going to say, yes, there is, and there's downstream consequences to that. So
Yeah.
one, you're not feeling all the emotions that you should be that are appropriate to situations. So some people say, I feel dead inside. I didn't cry,
Hmm. Hmm.
at my uncle's funeral, and my dog died and I just couldn't feel anything.
Yeah,
That's
I just feel
dangerous.
numb. I've heard a
I
lot
feel
too. Yeah.
numb. That's
Hmm.
dangerous to our collective humanity. We don't want to go through life as if we're zombies. It affects relationships, interpersonal relationships, connections, and we have good research that it decreases empathy. Empathy, our aspects of the brain are activated through empathic attunement to another person. It's how we care for each other. So there's something that's quite sinister about these drugs in the way it creates emotional detachment. We've seen it in marriages. Like, couples have talked about, like, my wife or my husband went on this drug and then they just weren't the same. Like, they didn't care, or they detached. And if you do have that like almost manic kind of response to the situation, we see there's an increased likelihood of infidelity and a number of other problems. People make decisions on these drugs that they wouldn't have otherwise made. So these are some of the side effects that we think are because you're fundamentally altering who you are as a human being by taking these drugs.
Yeah.
Now, how do you get off these drugs? It's very important for me to say you cannot abruptly stop it. Some of our worst crisis situations occur under certain conditions. Starting a drug, abruptly stopping that drug, adding a new drug, increasing and decreasing dosages. Okay. So that's like a very, very dangerous time. And what we're seeing is doctors are routinely withdrawing people from their drug way too fast, adding new drugs routinely, not aware of the consequences of doing so. So what we're having internationally is a revolt of harmed patients, which has allowed to start investigating how to safely taper off these drugs to prevent long-term adverse consequences. And what we know is slow and steady is the way to do it. And sometimes it takes at least a year to do so, not 4 weeks, not 5 weeks. There's something called the Maudsley method when it comes to SSRIs. But there's a range of other psychiatric drugs that people are taking that they need to be very slowly tapered to make sure that there isn't some protracted withdrawal. So I can't speak enough about the seriousness of the drugs and how careful we have to be when getting off. It has to be under medical condition, um, being observed. Hopefully you're working with a therapist where you're monitoring this and you have contact that person in case you do feel suicidal. This happens quite frequently in the work that I do because I'm outspoken, so people know it's safe to come and say, how I want to get off of these drugs. And I find myself coaching the prescribers on the Maudsley method. They've never heard of it. What are safe tapering guidelines? Or I say, hey, listen, doc, I think you're doing this way too fast for this person. Right. And so you try to do this, quite safely. And I'm interested in like, what are some other things that can also be done to mitigate the effects? Does diet, exercise, other lifestyle factors help
Yeah,
almost protect you and such things? We don't know a lot of these things, Nikki, because they're not researched and they're not
yeah,
studied. A lot of
okay,
these are driven by patient movements.
yeah,
We did talk about sexual dysfunction in the previous one. So a lot of people are saying, hey, listen, I took this drug and I just don't really have much of a libido anymore, or I can't orgasm. And people are asking, is that potentially permanent? And the answer is yes. For some, it's called post-SSRI sexual dysfunction. And that's why when I talk about the weighing the pros and cons of taking this drug, you have to make an argument for me how it anyway someone's going to take a risk where you can increase your suicidality, have permanent sexual dysfunction amongst a risk of other conditions. And how can you weigh that against this identification of depression, one that historically has informed us that is more likely going to resolve itself on its own? So the treatment has become the disease. The way we're intervening is becoming the problem. And we have to prevent more people from going on the drugs and now
huh,
open up research and dedicate research money on how to safely get off the drugs, like which one at one point, at what, when you're polypharm drug, which are you going to try to taper off first? And how do you safely do that? And so that's where we need to dedicate money.
wow, yeah, oh my gosh, that's a lot. I it makes me so sad. I don't know a ton of information about the sexual dysfunction, um, how many people are affected by it, I guess, who are taking SSRIs. And we have a couple more minutes before we need to wrap up. And so I do want to give people a little bit more information about that. What is it about um, serotonin reuptake inhibitors and their cousin drugs that actually cause sexual dysfunction? And is there something that can be done to mitigate that, while you're tapering, or, is there anything that we can do to help people who are permanently affected by it?
Yeah, unfortunately, right now we don't know. I recently had a conversation with a urologist. He says, "Listen, we prescribe SSRIs for people who have premature ejaculation." So they've known about this for a long time that
Oh,
SSRIs interfere with sexual functioning, and I've done
huh.
research. I'm trying to work on behalf of some clients. We know that there's a bidirectional relationship between sex hormones and serotonin, like the activation of serotonin 1A receptors, like enhance sexual desire. Serotonin 1B and 1C receptors decrease sexual desire, inhibit orgasm. So if we are altering serotonin levels with chemical compounds made in a factory, we are influencing the delicate balance of of an organism that is so
Yeah, yeah,
complex.
yeah.
Over hundreds of thousands of years, we've evolved to. Where do we get the hubris to believe that we can play God in this way without consequence?
Oh
Um,
my
a,
gosh.
a,
Yes, this is going through my head right now, exactly as you're saying that. I mean, yeah, how do we get to a point that we have oversimplified the human condition so much? I don't get that.
yeah, it's
To
so it's
one
so
hormone, one neurochemical?
it's so dangerous, and we became susceptible to it, and it just speaks to the vulnerability of human consciousness and how easily we can be manipulated when we are not critically thinking and we fall into group think, and then there's authorities that we have to defer to. And then that's something I think that COVID has allowed us to recognize,
Mm,
is that
mhm,
the
mhm.
medical authority, whether that's a public health authority or whoever we assign experts, when we defer to them and we no longer critically analyze and protect our own welfare and that of our family, that we put ourselves at risk. And so what I wish I could say that there was an easy answer. There's organizations like PSSD Network. There's a lot of funding efforts out there that exist that trying to research this to try to see if
Okay.
it's reversible. And I'm hopeful because of neuroplasticity and how we're such adaptive human beings.
Yeah.
Like we're
Yeah.
quite resilient, and so I am hopeful that they're gonna find a way. But the best preventative approach is to not fall into the cult of this to begin with.
Okay. Awesome. Fantastic answer. Love that. There's one more question that was posted to us from oh, actually, I see it. There's our second question. Um, there's an earlier question that was asked. I'm just gonna read those out, both of them out loud. There's two left, and then after that, I'll have you just quickly summarize um, your key take-home points from today and tell people how to contact you. So question one is opinions on, I'm assuming it's pronounced viral, VRIL. I don't know if that's a drug. And then the second question is, are SNRIs similar to SSRIs in terms of poor efficacy and iatrogenic harms or risks? And that one came from Allie Deborn, is with us on Zoom. If you can answer those two, and
Yep.
then give us a quick summary of your key points and contact information, that would be awesome.
So
I know
regarding
we have to
any
get going to actually take care of patients.
yeah. Regarding any specific one drug, I don't want to provide any recommendations. One of the things we know about drugs is they affect everybody differently. Be aware of the risks and the harms. Um, there is no situation where I recommend what we label as antidepressant drugs to any clients anymore. There was a time when I was younger and I kind of just accepted what was told to me, and I decided to really commit to investigating all of this. And I don't believe that any potential benefit is going to outweigh the potential harm. So under good conscience, I can't recommend being on and any drugs. SNRIs are just another drug that's targeting um, not only serotonin, but also norepinephrine, right? So many drugs are going to influence specific neurochemicals or brain chemicals, street drugs as well, alcohol. This is just a targeted intervention to increase norepinephrine. The problems and concerns are quite similar. There's no difference between the antidepressants as far as SSRIs and SNRIs as well, along the potential risks that I discussed today. Um, so of course they might when you increase norepinephrine, you're going to potentially increase activation. So there's a higher risk potentially of mania. But again, it's the same thing with all these drugs. People are different. They affect people quite differently. There's a range that exists in the way we metabolize drugs, your condition, your biology. And so some people seem to be uh, just fine taking the drug without anything outward that we can notice. And then there's other people who are harmed significantly. Um, I think about things in terms also of long-term metabolic well-being and metabolic health. So sometimes what we put into our bodies, it's not necessarily observable early on, but the
Mhm.
consequences long-term because we are disrupting a system, a greater system that works together, fundamentally intelligently designed, and so we don't always know the downstream consequences. So when you do take a psychiatric drug long term, what is the effect on our cardiovascular health, our ability to metabolize food, becoming insulin resistant, and so forth? Like these are factors in understanding chronic disease epidemic that we have to be aware of in our attempts to try. And listen, I can, there's some positive aspects like that you try to decrease human suffering. In our attempts to try to decrease human suffering in the short term, we're creating long-term chronic problems that are worse than the original one. And that's a big take-home message for me,
Yeah.
as well as the ethical and moral aspects of this. When we have this information, We have to make sure that we think about the ethical implications and that everybody who is provided a prescription is given the information to make an informed decision on the risk benefit profile.
Love that lovely summary. And a comment that was made on social media, I think highlights the gist of that summary that you just gave us. I'm just going to read that one out loud. I took Paxil for social anxiety. It worked extremely well. However, it had pretty much every side effect mentioned here: loss of enjoyment and empathy, temporary sexual dysfunction, bad withdrawal. So I think that effectively summarizes just the fact that this person thinks that it did help, and it was, it worked extremely well, but also recognizes that it had those side effects with it, is something that we actually have to, um, signals that we have to change the conversation about this. And so what we've talked about here today, I hope that it is going to benefit people who are watching, people who are interested, people who are prescribing, and also patients who are recipients. Um, and um, and also, seek out clinicians who are conscious of these things, just like yourself. So how can people contact you, and or also, just get in touch with your work? Gavin just put in the chat links to your work. Is there anything else that you want to leave people with, or with a way to contact or connect with you?
Yeah, a final comment, because I thought that was such a great question, is because
Yeah,
it's important to note that social anxiety is really helped by alcohol as well. So
yes,
we have to
that is very
remind
true.
we have to remind people that what we identify as what works doesn't necessarily mean it's good for us, right? Well,
Yeah,
people drink alcohol in order to deal with social anxiety. As
yeah,
far as I'm concerned, like even this conversation today is going to be released on the Radically Genuine podcast. I thought it's an important one, and I said a little bit about fair and fair in medicine to start. I pre-recorded something because I'm in such support of the organization and its principles. And so I'm just really grateful to be able to have this conversation today. It's organizations who are willing to have this, even though it's uncomfortable, even though some people may be hearing this stuff for the first time and it's hard to believe. The willingness to have this conversation is really important. The other thing is, the Conscious Clinician Collective is an initiative. You'll be able to see that you'll be able to access that link in there. We're trying to coordinate people who are part of this movement, who care about medical freedom and informed consent, and want to make sure that you have all the information in order to make a medical decision around mental health. Because what I'm getting from families is that not only are doctors not aware of this, some of them are pushing it on parents and saying, if you don't give your kid this drug, it's negligence or it's even child abuse. There's been threats at hospitals to hospitalize their kid and to accept the psychiatric drugs that they're prescribing. And this is happening in American communities every day. I wish that doctors were as informed as you, Dr. Johnson, but to me, it hasn't been my norm. It hasn't been my experience. And we're
yeah,
working in a system that's providing more harm than good, and so people have to know their rights. And I've often had to be able to assist people in reminding them of their rights as parents and as consumers and individuals, that you don't have
yeah,
to take a drug that you don't want to take,
yeah.
and be aware of the risks.
Well, as a, thank you for the compliment, but honestly, I can tell you, because I left clinical practice in 2022, I did ask a lot of questions. I was one of those people who did, question and push back on things, but at the same time, I was indoctrinated by this as well. And so the reason why I work for FAIR is to inform people about these things. And I'm also learning a ton about this from people like you. And so thank you so much for joining me as a guest. Thank you for all of you who stumbled upon this conversation, or those of you who came here intentionally. Reminder that Fair for All is run entirely on your donations and your support by sharing our work. We continue to strive to offer programs that are similar to this. We want you to be educated about topics that actually, benefit you. We hope that the work that we're doing, overall, and today helps bring awareness and solutions. We want to, our overall aim is to return medicine and healthcare, the health profession, to an emphasis on Hippocratic medicine. We hope that you will continue supporting FAIR with sharing our work, watching our webinars, participating, and also with a donation. Find out more about our work, please go to fairforall.org or directly donate by going to fairforall.org/donate. The links in the chat and show notes will take you directly there also into Dr. McFillin's work. Thank you all for joining us today.